And the last topic, the last winner for today, aortic stenosis. If we go with the same concept for this, what is the prevalence of this? In the United States by itself, more than 2.5 million people with aortic stenosis. This one is the most common valvular disease. When we reach the 70, about 1% of us will have aortic stenosis. When we reach the 80, more than 7% of people will have aortic stenosis. What is aortic stenosis? So the aortic valve is this valve in the heart connecting the heart to the major artery that let the circulation go to the body. It has a 3 leaflet. It looks like Mercedes-Benz, but this is the outlet of the heart that let the blood goes out. In the normal valve, it looks like that. That's when it's open, that's when it closes. It's open and closed with each beat. There are different diseases could cause this valve to go bad. One of them, rheumatic fever, which we don't see as often as in the past, but calcification, because of wear and tear, because of certain risk factor, people build a lot of calcium and this valve become tight. Now you see, this is when it's open, doesn't open all the way compared to this valve. There are certain anomalies, some people born with it, like they may have different anatomy, could cause them to have aortic stenosis. And this usually happens in younger age. We see it in 40s, 50s. So similar to the hose you have at your garden, when it's wide open, the water flowing easily, there is no problem there. If you start pinching it or you see the hose get narrower, it's become harder for the water to come out. So you feel the pressure. And that's what the heart feel. When this valve get tight, that's what the heart feel. It feel a lot of pressure building up to keep the blood going out. So the famous professor Brownwald, he studied the natural history of this valve. People could build calcium over this valve and go years. They don't feel it. But at this pivotal point, when they start having symptoms, things go off a cliff very quick. And 50% of people, after this point, they don't live more than 3 years unless they get this problem taken care of. Symptom-wise, as I said, too many years, no symptoms. When this valve becomes severe, they start having symptoms. Often they start with people noticing they have more shortness of breath when they push themselves, doing activities, exercising, climbing the stairs. A lot of people adjust for it. They blame it on age, they blame it on not being active, they blame it on the weather, but sometimes it could be sign or signal that the heart is struggling a little bit to keep up with the demand. When it progresses more, people may have shortness of breath even sitting or laying in bed. In extreme situation, they may lose consciousness. When the heart cannot keep up, they may have heart failure. In certain situations, they may have sudden cardiac death. The purpose of this call, not to scare you of all of that, probably it is scary, but the goal for you to be aware of what kind of symptoms you could watch for, so you get that identified and taken care of early. But we know we all are human, we all have these kind of risk. Our job to be just diligent and smart about it. There is no treatment for aortic stenosis with medication. So when this calcium build up, it's gonna be there forever. But there are good solutions for it. The first solution came for fixing this problem is replacing the valve, taking this valve out, putting a new valve, and that's what they did for years and years with open heart surgery. And this has evolved over the years, technology and different type of valve, mechanical valve, tissue valve, and so on and so forth. But there are smart people like Dr. Anderson here, who was still in the training doing cardiology. He went to one of the conference and he was thinking, now when we have blockages in the arteries in the heart, we can open it up, we put the stent, we push everything, and things are fine. We get the flow back. Why don't we put just big stent in this valve, we open it up to help the blood flow? Interestingly, he designed this valve, he did it in the garage of his home, and he took it to the hospital. At that time, there was not very stringent regulation. He bought a pig and he was doing experiments with this pig. No one believed that. No one thought, okay, well, you can do it without opening the chest, just going through catheter and you replace the whole valve. It was a very complete novel concept, but he was persistent. And the first surgery was done in 2002, Dr. Kreber in France, and that's the famous patient who received the first transcatheter percutaneous minimally invasive valve replacement. And the interesting part of this story, that's the same doctor, Dr. Anderson, after about 40 years of him coming up with this valve, that his dad received the same valve that his son invented and got benefit of his son's invention. This technology, it's also evolving very, very rapidly. The device is becoming smaller, the procedure becoming less invasive, recovery becoming quicker. So there are 3 devices FDA approved available for us, we currently use. There are a lot of other devices in the pipeline, different design, different mechanism. And since 2016, the number of procedures done percutaneously, minimally invasive, already surpassed the number of surgeries done with open heart surgery. It opened a huge door for people who were not candidate in the past to have open heart surgery now, to have it with percutaneously. The procedure take about between 45 to 1 hour, 45 minutes to 1 hour. We expect patients to be up walking on the same day. Most of them, they leave the hospital less than 24 hours. Within a week, we expect them to do more than what they used to do with this procedure. This is one of the procedures I have done. So here, we put some contrast, some dye to see the artery. We inflate the balloon. It expands the valve. It pushes the old valve to the side and sit in a place. And that's done. The deployment of the valve, it takes less than 30 seconds. So after that, we pull all the catheter, we check the valve, everything looks good. We are pretty much done with this procedure. Is it for everyone? It's not for everyone, but most of the people could be candidate for this procedure. We still evaluate each patient to make sure we give them the best choice. Some of them, because of young and healthy and other things, may need to go for open heart surgery, but a lot of patients, the majority of them, they could be candidate for the minimally invasive procedure. But our commitment is to the patient to make sure we give them the best choice that is suitable for their case. With this, I would like to thank you again for being a good partner of the Methodist, and I hope you all learn from this conversation, and happy to answer any question. Thank you.